Welcome to the AVF Podcast. I am Jeff Palo, your host for this edition. Today, it is our great privilege to have Professor Younsuck Koh from Asan Medical Center in the University of Ulsan College of Medicine in Seoul, South Korea. Professor Koh is a leader in Asian critical care and was the past chairman of the AVF. In 2015, Professor Koh was one of our senior authors in a study looking at practices of withholding and withdrawal of life-sustaining treatments in ICUs in Asia. And this included responses from almost 1,500 ICU physicians from 16 countries. So today we will be talking about this difficult topic, which is patient autonomy at the end of life in the ICU. Good morning, Professor Koh.
Thank you for kind introduction, Dr. Jeff Fallow.
Hello again. It is a difficult topic, actually. So it was actually difficult to figure out how to begin. So my first question will be, what are the best ways to understand and uphold each patient's autonomous decisions regarding end-of-life care in the ICU setting?
Thank you for your question, because your question is at the heart of end-of-life care, because the two key values for appropriate end-of-life care is respecting patients' autonomous decision and promoting the patient best interest. And the autonomy is a capacity to make an independent, rational choice. Truly respecting patient autonomous decision is the justification of our current medical practices. The problem, in clinical field to respect patient autonomy is that autonomy is quite easily, influenced by various factors, especially at end-of-life care stage. It means that the autonomy individually from point of the view of caregivers, it is important to promote and to uphold the patient autonomy, addressing patient physical, psychological, social, and the spiritual issue. That's the reason why end-of-life care discussion is not easy. If the patient has a firm desire to end-of-life care, it is relatively easy for caregivers to provide the appropriate end-of-life cares. The doctors may to see if the patient wishes are in line with the patient best interest, and to determine whether the patient wishes are not conflict with the relevant medical law of the country. However, it is not common, to find the patient wishes. Therefore, we should discuss with the patient or patient family in individual issues to know the patient wishes on end-of-life care. In that aspect, it is important to begin end-of-life care discussion at earliest possible stage of patient illness. If the disease has progressed, it is difficult to determine wishes directly from the patient.
Yes. So I know that it is difficult to actually discuss this from a very general standpoint, because as we found in our study, Asian practices are so diverse. So I think I would like to focus on your local context. So how does it work in South Korea, and how would you be defining and making sure you're upholding the patient's autonomous decisions?
According to our government statistics, more than 70% of the patients die in a medical facility here. It means that the caregivers are more involved at patient, the end of life care compared to previously, the past years. In each period, more patients die at home. In Korean society, there has been a social movement for preparation of advanced directive earlier, and on determination act on withdrawal of life-sustaining treatment, which applies in clinical field since 2018, highlight the importance of self-determination during the end-of-life care here. However, the law allows to determine withhold or withdrawing end-of-life care only in the stage of last weeks or last days of patient life. It means that quality of end-of-life care could be different depending on how the doctors determine end of life of the patient. So more than almost two-thirds of end-of-life care decision, however, still made by families' consensus with estimating or unknown patient risk in here still.
Yes.
And also the end-of-life care education for caregivers has been active since the act applied in clinical field. I think though the caregivers are more interested to follow the procedures stipulated by the law instead of to promote patient wishes. So even in Korea, we caregivers should try to let patients to express their autonomy better when we are doing end-of-life care discussions.
So how does a family decide if their patient is unable to express their wishes?
Family decision is very common in Asian countries when we make end-of-life care decisions. Individually, patient families' surrogate decision is influenced by patient wish and survival chance and suffering and quality of life issue and family culture and also the nursing burden. More than that, as shown in our the previous study on the end-of-life care in Asian intensive care unit, medical expense is the important factor to influence the family's decision. As the proxy decision, surrogate decision, and make a proxy decision, patient interest should be prior to the proxy's interest. However, as Asian is the more dominantly familiar culture. Mm-hmm. So in familism, the patient, family's consensus opinion is regarded higher, frequently regarded higher than patient own, and also sometimes family's interest could be prior to the individual patient interest. In clinical practice, as you already experienced too, patient they openly defer their decision to family. The problem is families, the unaware of their patient wishing. It is partly, due to our Asian culture. In Asian culture, the family is quite reluctant to discuss about the deaths, with their patient. And even in a hospital, the family sometimes request that doctors refrain from having this end of life care discussion with the family. So the surrogate decision is common in Asia. However, regarding the appropriate approach to surrogate decision is not easy when we made an end of life care discussion. Moreover, as you also the experience, the family patient sometimes withhold their wish, considering family's burden of end of life care, cares. Do you agree?
Yes, it is very challenging, and although our countries have differences, a lot of what you have said is true also in my own country. It is difficult to generalize to all Asia because we know that there were differences. But you mentioned earlier about an educational program for families. Actually, when the law in 2018 was pushed forward, so that is amazing. That there's actually a push for that. Could you tell us more about what kind of education a family gets regarding
I did not mean the family, for the caregivers, for the doctors.
The doctors. Oh, I see.
Because in Korean, the Determination Act to withdraw life-sustaining treatment, they stipulate the process quite in detail.
Okay.
So the doctors should comply the procedures and should make the all the papers to submit to the health authorities. So that's the reason I would say that the doctors more interested to comply the process stipulated by the law instead of to uphold the patient autonomy.
See. And did you find, since we are in the middle of this pandemic, did you ever find that the pandemic actually changed some of the proxy decision making regarding withdrawing or withholding elements of critical care?
It is the quite pain of the patient or their families who died without being appropriate medical service. Even in the hospitalized patient, most hospital have limited the patient families access to patient concerning the COVID-19 spread. It leads the caregivers to prepare advanced care planning earlier in appropriate time. By the difficulty to have a communication opportunity with the family, especially under the situation with the ICU bed shortage. It is caregivers have a difficulty to communicate patient family, having discussions through the phone instead of face to face.
Yes.
About the patient condition and level of care. That is another the difficulty to make an appropriate the surrogate decision. Families are also having difficulty in making end of life care decisions, solely depending on the attending physician's suggestion without directly seeing the patient. So the both sides have the difficulties to make appropriate the end of life care decision. I think that is the reason why we need socially agreed and publicized the triage, the guideline. If the socially agreed and well prepared guideline available, that helps to alleviate any ethical conflict between caregivers and patient family regarding admission and discharge, the decision, or also the end of life care decisions. So it is quite the peculiar situation we encountered, especially regarding to end of life care discussions, and the families cannot share the times when the patient, their loved one, to die in the hospital.
Yes, it's difficult for all sides, and this pandemic has just made a difficult topic even more complicated. I wanted to go back to what you said about a socially accepted and publicized triage protocol. Is there something like that in Korea or in your locality?
Yes, the Korean Society of Critical Care Medicine had prepared. I would say that, as you know, the adequate allocation of scarce the medical resource through the well-prepared guidelines is very crucial, to cope with this pandemic crisis. Triage guideline for critical ill patient admission is one of them. The triage guideline aims to maximize the benefit of saving lives, and also to reduce a situation of unfair access to care. I know, some guidelines issued from other, the medical societies. However, I'm not sure whether the guidelines performs well in their society. It is the same in Korean society. Korean Society of Critical Care Medicine had the prepared guideline, and also tried to publicize to the society. However, the guidelines were not well publicized and was not adopted as a healthcare policy by the healthcare authorities. So it is a pity, I think the most Asian countries encounter the similar situations up to now. So in Korea, as you know, each hospital take care of the COVID-19 patient as many as the bed the government allocated. So that is the current situation.
So when you say publicized, is the general public, the non-medical public, also knowledgeable about the triage guidelines, or is it just the healthcare practitioners?
We in Korea, it shared among the intensivists, but although we had the interview with the news media, it was not well, considered to the publics, and the news media also do not much, consider the importance of any triage guidelines. So it means that the publics and even caregivers do not understand well what principle is carried out for the patient management under the pandemic crisis, and also that can make the ethical, the emotional conflict. Why my patient is not treated well, without understanding the any triage and or also the resource sharing. So it is, I think that quite similar in globally.
Yes, I can imagine that if in a media interview there is already friction happening regarding the lay understanding of end of life care and triage decisions, then I'm sure that this kind of friction occurs at bedside a lot. Um, so, in your context, what kind of what do you see regarding how teams communicate to families and how they try to resolve these kinds of frictions when they do occur?
Uh, the Regarding to family discussion on the end of life care, although the recent situation is very different than our usual critical care situations, meaning that our usual critical care, we can easily share through the frequent family discussions.
Mm.
But in these days, the family's access to the patient, especially in the ICU, is quite, the limited, and they just only hear the patient condition through the over the phone. So it is a very different situation, though. However, to address the any end of life care issues, even at this stage, we should the caregivers should try the more frequent communication with the patient family, addressing the what is their difficulty encountered in maintaining the critical ill with the COVID-19 conditions. So the another the important issue is during the communication with the family, we should carefully listen the family's the request without interrupting their saying. So that is also the a key to facilitate the communication with the family.
So these are already specific techniques of active listening and making sure that that the quality of communication is guarded, even if the pandemic has forced us to communicate in other ways. I think that the what you just said was a very important thing because at the time that our tendency is to communicate less, families and patients actually need um, more open communication about their diagnoses, the treatments, their prognoses. And it's challenging already in the very beginning, and it's now more challenging because of the pandemic.
Yes.
Um, do you have other recommendations regarding how a clinician, like me, for example, would be going about talking to people and understanding more about what how they want their patient or themselves to be treated?
Um, the in Asia, I think that to get the family's consensus is very crucial to provide appropriate end of life care. So when the patient family got the burden of a medical expense, especially,
Mm.
or the patient previous condition was not the appropriate, meaning that long time sick or the any quite bedridden state, for example. Frequently in the clinical field, the futility controversy over the management commonly occur. So as you know, the futility is a matter of a value. could be differ between caregivers and families. So especially in this period with the limited opportunity to communicate with the family, I think the first time meeting or communication, either face to face or over the phone, is very important. So it means that the caregivers should prepare how to explain or how to get the consensus from the patient family regarding on the patient current condition and the management plan and the probability of recovery. The caregivers should organize the information to deliver to family. So without the well preparation and begin to communication with the family, it is very difficult to raise on the end of life care issues, especially in the first time communication with the family, because you could be quite commonly misunderstood by the family when you do the family discussions in the first time stage without talking the detailed management plan. If you raise the issue of end of life care, that the families may misunderstood you. Mm-hmm. So that's the reason. However, you should raise the issue when do the first meeting, because the critical ill carries the probability of death in any condition. Mm-hmm. So therefore, the first time meeting is usually families are quite keen to the doctors the explanation or suggestion. So if you approach cautiously regarding end of life care issues, especially such as the do not resuscitate order, after addressing the management plan and the chance of recovery, meaning the prognosis, prognosis, the suggestion, then if you cautiously, raise the issue, from my experience, families quite understand why, this doctor raised the end of life care issue. So I would like to say the first time meeting with the family is very important for the future appropriate end of life care, care. If you do not raise the issue of end of life care at early stage, you families got suspicions regarding the end of life care issue raiser after patient deteriorate.
I see.
Whether the caregivers do any manage not well. So such kind of misunderstanding commonly often. So if you raise the issues at the early stage, you may get more easier understanding when you suggest any end of life care if the patient seems to be not unresponsive to your management. So that is a very important aspect when you do the family discussion. And another thing I would like to suggest, the caregivers should not give pressure to family by saying that patient life is important. They know that their patient life is important, but when we during discussions, if the gap of the understanding is huge. Sometimes young doctors say that your patient life is important. So that makes the patient family together angry.
Yes. Well, thank you for those two insights. And I think that even though we practice in very far apart from each other, there are some universal truths, I guess, to how to go about this difficult topic. So communicate often, communicate early, be careful what we say, I think is what are universal. Um, it is a difficult topic. There are many directions where we can go with this. Unfortunately, we are a podcast rather than a complete workshop, and I think this kind of discussion is needs more time. Actually, unfortunately, we do not have that. So, do you have any last words for our audience who are
Yeah,
surely dealing with these
you know
challenges?
I would like to to comment regarding the ethical difference between the withholding and withdrawing.
Oh, sure, of
Yeah,
course.
yeah.
Sorry.
In our previous studies, 90% of Asian intensivists discriminate withholding and withdrawing. I would say there is no ethical difference between withholding and withdrawing in last phase of the patient life. Unresponsive treatment, if you the prolongs continues the unresponsive treatment in your patient, meaning that prolongs patient suffering, prolongs time to death. So please, when you shifted from intensive care to comfort care, please keep unessential any laboratory finding, the laboratory reps works, and also the please kit withdraw any invasive intensive care. So many doctors say that, oh, we just withhold the further management, maintaining the current treatment.
Right.
That means that the doctors discriminate withholding and withdrawing. So when you decided to shift to the comfort care, you should withdraw all unnecessary management.
Right. We need to understand what our goals are, and if things do not meet the goals or work towards the goal, then they're not necessary anymore. Yes.
Correct.
It's a
Yes.
very important insight too. Well, we are at the end of our podcast, and I would like to thank Professor Koh for his time. Um, we have spoken a lot about basically how to communicate more at bedside within the context in the beginning regarding how it is practiced in Korea, but we find that a lot of the things that we have spoken about are actually universal. So again, thank you, and we will see you again at the next edition of the podcast. Thank you for listening.
Thank you, Jeff.